Okay, well, thank you. It seems like 2 minutes can seem like a long time at times. Anyway, I hope you all completed your poll. I'm going to briefly introduce myself. I'm Dr. Anna Giuliano. I am a professor and director of the Center for Immunization and Infection Research in Cancer here at the Moffitt Cancer Center. I also have the great honor and privilege of being the president of the International Papillomavirus Society. And it is this society that created the March 4th HPV Awareness Day, which we're now going on, I think it's 7 or 8 years that we've actually had this date reserved worldwide just for awareness around HPV infection and all the diseases that it causes. And importantly, what we can do as a community to prevent all of those diseases with simple interventions and what we can do to prevent people from dying from the cancers that these infections cause. So just briefly, I am a cancer epidemiologist, and most of my work has been with prevention studies globally. We've been doing this now with public funding from the NIH since 1990. Most of my work is focused on understanding HPV natural history at all the anatomic sites that cause cancer in both men and women. And as I said just now, I am the president of the International Papillomavirus Society. We host an annual meeting, and I hope there are two things. I hope you all join the society and take advantage of all the resources that we have, as well as come to our annual meeting. This year, it'll be in Athens in October. So we welcome you. Okay, next slide, please. So next slide. So HPV Awareness Day really is global. In fact, one of the things that as a society we are so incredibly proud of is how the number of countries and organizations within countries have joined us in this effort. And now I think it's exceeding 100 different countries with multiple community organizations within those countries. And what you can see with this map is where everybody's located. So it's everything from North Africa, Sub-Saharan Africa, Asia, Europe, South America, Central America, and of course here in the United States. So you are joined by people from all over the world, all of us having a common goal in mind, which is the elimination of these cancers and other diseases that HPV causes. Next slide, please. So oropharyngeal cancer is a cancer that we had always been thinking about was rare and, hardly anybody talked about it. But as you can see from this pyramid, we are seeing a major shift in the epidemiology of the cancers that HPV causes. It used to be here in the United States that cervical cancer was at the bottom of the pyramid. It was the cancer that had the most cases. Because we have cervical cancer screening and treatment and now also vaccination, we've been able to reduce that incidence, which is really the good news. However, there's still too many women who are diagnosed with cervical cancer. And for this reason, I really like to focus on two very important cancers, cervical among women, but really to raise awareness about the growing number of cases of oropharyngeal cancer, a cancer that predominantly affects men. In fact, we see 4 to 5 times as many men with oropharyngeal cancer than women. And collectively, cervical and oropharyngeal cancer tell us that it is essential that we have prevention interventions that is for both males as well as females. This is a shared virus with diseases that affect both males and females. And unfortunately, unlike cervical cancer, there is no screening for oropharyngeal cancer. So it really shows us the importance and the necessity of vaccinating males as well as females. Next slide, please. So how do we do this? How do we eliminate HPV-related cancers? Well, with cervical cancer, it's very clear. It's a three-legged stool. We have the vaccine to prevent the infection that ultimately leads to precancerous lesions and cancer. We have screening, and we have all these new modalities for cervical cancer screening that really are going to help facilitate getting women screened in an accessible and in a respectful way for all women in the United States. So we have self-sampling, we have pap testing. A lot of it is dependent on HPV testing, which is really a superior test to what we've had in the past. And then, of course, if a lesion is detected, a precancerous lesion is detected that needs treatment, women need to be treated so that we reverse the cervix to a normal epithelium and prevent that cervical cancer. By doing this, we should be able to reduce the number of invasive cervical cancer cases observed here to under 4 per 100,000, in which case we will be meeting the goal of eliminating cervical cancer. Next slide, please. So where are we in the United States with cervical cancer incidence? The color red always tends to be that worst color, isn't it? And in fact, on this graph, what you see is that the states that are colored in red are the states that have the highest incidence of invasive cervical cancer. And one of the saddest things for me to speak is that here in our state of Florida, we have among the highest incidence of invasive cervical cancer in the country. And in fact, unfortunately, that is shared by our neighbors of the other states in the Southeast region. And for this reason, you'll be hearing from our dear friend and colleague, Heather Brandt, in just a couple of minutes, where she has helped to build the Southeast Coalition. We need to partner. It's not just us. And if we can share experiences and share best practices so that our here in Florida, as well as the entire Southeast region, can reverse this color to blue instead of red is our goal. Next slide, please. So we have known for years that women of minority populations experience a much higher incidence of cervical cancer than white non-Hispanic women. And unfortunately, after all these years, this is still an issue for Black and Hispanic women. As you can see with the dark red boxes in the figure on the right, the women who are non-Hispanic Black as well as Hispanic, which is a line directly under that, have a significantly higher incidence of invasive cervical cancer than do white non-Hispanic women. Next slide. When we look at vaccination rates, remember that was the first leg of the three-legged stool. We say, are we getting vaccine out there? And we have made progress, so I don't want to be too depressed about it, but we still have a long way to go. What you're seeing here in this figure with the top lines are the rate of dissemination of Tdap as well as the meningococcal vaccine. And these are vaccines that are delivered to the same target population. Remember, the ideal population for vaccination are the adolescents. And under that, you can see that we have made progress with the number who have received and the percent who have received one or more doses of the HPV vaccine, but we're nowhere near the goal of 80% vaccinated, which is our US national goal. And if you look at the number who've received up-to-date vaccination, meaning 2 doses or more, the percent is much lower. We're at around only 60%. So there is a lot of room to improve this and a lot of room to increase the prevention benefit to our population in the US. Next slide, please. What we see, and this is true for both vaccination as well as screening and treatment, that the vaccine coverage is highest in the urban areas, or spoken another way, the vaccine coverage is lowest in our rural areas. There are probably a lot of factors that are influencing that, from community level awareness and understanding of the vaccine in the rural areas, how providers are speaking to their families about the need for vaccination, and so on. But it really shows us where we need to be targeting and focusing our efforts to improve this. And that is very much so in the rural areas. Now, we still have work to do in the urban area to make sure that both males and females receive vaccination so we can achieve that 80% coverage. Next slide, please. So where are we in the state of Florida? So there have been some improvements. If you look at this slide, on the left, you see we're looking at the completion rates in 2023, and we find that overall for Florida, it was at 44.7%. So that's a far cry from 80% that is our goal. And if you look on the right, you can see that it has increased, but it is really a minimal increase. We're only at 45.5%. It's less than a 1% increase in the coverage of vaccine. And if you look at where in the state are the counties with the lowest rate of vaccination, again, and there's that red color. In this case, I think it's a bit orange, but it's still highlighting clearly where the gaps are, and they are in the Panhandle and in more of our rural areas. So very much so supporting the national data that we've seen showing that people in rural areas have lower rates of vaccine coverage. Next slide, please. So what are we doing? We are working as a coalition across the counties, across our cancer centers here in Florida, as well as with our partners in the Southeast states. But we're doing that in the setting of changing vaccine policy when we're trying to eliminate these infections and diseases. Next slide, please. As many of you have probably heard, there has been a lot of disruption at the Centers for Disease Control with respect to vaccine policy and vaccine recommendations. And in fact, we've seen this online, which is we are waiting to get official notice. But in the meantime, next slide, please. It's very clear that the medical organizations that are most closely aligned with caring for children and adolescents as well as young adults, which is the American Academy of Pediatrics, has made a very strong stand to maintain the 2026 immunization schedule intact after what has appeared to be an overhaul and a chaotic past year at the Advisory Committee for Immunization Practices at CDC. So the AAP put out a very strong statement that the AAP continues to recommend vaccines to protect against 18 different diseases in its immunization schedule. And they released that in January 26th of this year. They make it clear that their recommendation differs significantly from the federal schedule that underwent an arbitrary overhaul. And it was an arbitrary overhaul because the usual discussion and debate and consensus that occurs across all the stakeholder medical organizations of the committee did not happen. So AAP has been publishing its guidance on vaccines for decades. They are the ones who provide the evidence and the guidance to their providers, which are pediatricians. So next slide, please. So it's not just AAP, more than 200 organizations announced their support for the AAP vaccine schedule. The reason this is important is that there are multiple types of health providers that vaccinate. So we need to make sure that it's not just pediatricians that are following what has been a consensus statement about number of doses and when doses should be delivered. But also the other practices that take care of adults, those who are older than 18, are family practice medicine physicians who take care of the whole family at the same time. And as you can see here, there's consensus across all of the practice groups that are involved in immunization here in the United States. So this is a very great it's a great counter to the chaotic nature of some of the decisions that we've seen from the CDC. Next slide, please. So what is that recommendation for HPV? AAP has made it clear that they're sticking to the 2-dose schedule, and the primary target population for that are adolescents. Next slide, please. So where are we with cervical cancer screening? Next slide. Here we see that maybe Florida isn't as horrible in terms of where we're at with screening as we were with vaccination. We've always been sort of at the bottom of the percent vaccinated. But when it comes to screening, we're actually slightly higher than the US average. So those who are compliant with these current screening guidelines, we're at around 66.5%, a little higher than the US, which is at 65.3%. However, the goal is over 80% should be screened. So again, we still have a lot of room to improve where we're at with screening. Next slide, please. So where are we in the state of Florida with this? Thankfully, we have a Florida Cancer Plan, and in that plan, the working group has prioritized a goal to eliminate cervical cancer, and that's goal number 6. And as stated in the plan, it's to eliminate cervical cancer as a public health problem in Florida by increasing vaccination against HPV and increasing cervical cancer screening and treatment. So we had this goal from 2020 to 2025, and the committee, in their infinite wisdom, has decided to continue to have that goal in the plan through 2030 and actually have developed a strategy for achieving that goal. So I'm confident that we're really going to make some good progress in the coming years. Next slide, please. So today we have the privilege of having multiple people joining us from around the state of Florida. I just want to remind everyone of our agenda. We have Tamika Felder with us, Heather Brandt from St. Jude's in Tennessee. We have Joe Thomas, who's here with us in Florida. Erin Kobitz from the Miami Cancer Center, and then, of course, Susan Vanderprample, who directs our community outreach and engagement program here at the Moffitt Cancer Center. So I have the great privilege of introducing our next speaker, which is Tamika Felder. Next slide, please. So Tamika is a cancer survivor and award-winning women's health advocate. She is the founder and chief visionary officer at Survivor Inc., which is a nonprofit that's dedicated to cervical cancer advocacy and support. I've had the great pleasure of working with her in multiple sessions internationally to help engage people from around the world with the same common mission, which is to eradicate cancer and shine a spotlight on the patient voice in healthcare. Newsweek has named Tamika a cancer rebel. And I'd say she's so much more than just a rebel, but I love the rebel part. She currently serves as co-chair on the National HPV Vaccination Roundtable, and she was recently appointed by President Biden to be a member of the National Cancer Advisory Board. And I should just let me update that. She was on with President Biden, but she continues to be on one of our most important national cancer boards that influences funding and programmatic activities for the United States. So kudos to the current administration that they had the wisdom to select Tamika. Ms. Felder is an award-winning television producer and host. And with that, I pass the baton to Tamika. Thank you.
Thank you so much for that wonderful introduction. I'm so happy to be here, especially on this day. I couldn't think of a better place to be. Next slide. So when I think about looking at those slides and knowing my own cervical cancer journey, I see this little girl who had all this hopes and dreams, and then cervical cancer came in, and I thought everything would be taken away. But now, because of research, because of science, this is me now. I get to be here with you all and share my story. Next slide. Never in my life, when I was working as a television producer and host, did I think my life would almost end at 25, especially because of a cancer that I had rarely heard of and a virus that I had never heard of and I couldn't pronounce at the time, human papilloma virus. But that was my reality. My life almost ended tragically with cervical cancer at the age of 25 in 2001. Next slide. You know, when I think about my cancer journey, I I sometimes can't believe that I'm still here because I've gone through so much. But again, I'm so thankful for not only the supportive community, but also for having the science and the treatment options available to me so that I can be more than just a statistic, that I survived it, that I am informed, that I am empowered, and I am thankfully alive. Next slide. You know, there are many gifts that come with cancer, but the truth is that gift is wrapped in barbed wire. Even if I'm with you all here today and I'm sharing my story, it's, pulling the Band-Aid off and reliving those things over and over again. But I do it because I understand that we can do something about HPV related cancers. It's not that we're hoping and wishing. We have what we need to make an impact right now. Next slide. And so you kind of have to know your why. And next slide. My why, next slide, was figuring out what can I do? Because when I was diagnosed, I wanted nothing to do with this stigmatized virus and cancer. I wanted to go back and never think about cervical cancer and HPV again. I didn't want to be labeled the person who had that type of cancer. But then I remember what it felt like in 2001 when the only support I found were in other GYN cancers, which I'm so grateful for. But I was like, where are the people in the patient communities talking about cervical cancer? Where are they? Next slide. So I started and worked and built what I didn't have. A place where we didn't have to hide our face, a place where we didn't have to say usernames and be with that stigmatizing narrative. Next slide. And you think if you build it, they will come, and that's not what happened initially. People would come and they would talk to me, but they didn't want to share publicly. And I get it because in order for me to share, I had to talk about what happened to me, how it made me feel, how it impacted me, and what I wanted people to know. And why would it help them? Why should they join this movement? Next slide. And it was connecting the dots. It was understanding that, there's all this science out there, but unlike other disease sites, where are the patients who can bring this data to life? Where are the patients who can say, I had this and I'm not ashamed, or I had this and it's very common? Next slide. And because we can eliminate cervical cancer, we need to share our stories. But you can't just have me and one other person or four other people or six other people sharing the stories. That's great. We need a movement, a global movement of people sharing their stories. And I get it. That can be scary. It can be overwhelming because once you put it out there, it's out there. Next slide. But somehow we did it with support and empowerment and our advocacy training. Next slide. We were able to get people to share their story. This is Avi Grant, who is a Florida resident, and she is a powerhouse at sharing her story. And we need more people like her sharing their stories because we have to change not only those numbers in Texas, but Florida and all over. We have to change. I was looking at that map, and even though there's been progress, there's so much work that still needs to be done. And I know that patients are also up for the challenge to support. Next slide. And so that means at Survivor, we have many programs for people to get involved in, and we want to join and partner with you. Next slide. We do mainly through our survivor schools because as someone who was diagnosed, I know firsthand where you just want someone to hear your story. You want someone to know how this cancer impacted you and what it did to you, and that I'm angry at it, right? And then you find out, well, this cancer, we can do something about it now. And so our survivor schools, next slide, speak to all of that. And we want to join and partner with you. So one of the reasons why I'm excited, and even though I'm under the weather today, I could not miss today because I appreciate whenever the patient voice is included. And so we have many more, but these are just a few of our survivor school graduates. Next slide. So for those of you who are on today, always think about including a patient voice. This is yet another survivor ambassador, survivor graduate, Patty Marilla Casa. Next slide. Katiana Faggi, who also had the BRCA1 mutation. Her mother died of ovarian cancer. She had cervical cancer, but she found out she had the BRCA1 gene. And for her to be so transparent about things. Next slide. And Anna Ogo, who's represented with us around Japan, here in the US, the Pacific Northwest. Next slide. And Carla Chavez, who some of you may know from IPVS and other things, who is in Honduras. Next slide. And our Kenya survivor ambassadors. Next slide. And so we look at all of you as our partners in purpose, right? We learn from you. You know, I often tell people, like, I don't have a medical background, but I've learned so much over the years, so from so many amazing people, and it gives me the confidence to speak about cervical cancer as a subject matter expert from my patient side, but also knowing the science that we can bring to life. Next slide. Dr. Noel Brewer is one of the people who helped me connect the dots that every statistic that's shown, there's a human being behind it. There's someone who needs this work, the real life work that you all dedicate every single day that we're so grateful for. Next slide. And so these are some of our partners. Next slide. And we know that when we partner together, that our personal impact stories have the ability to create change because we make it real. We make it something that's not just shameful, that's something that we can prevent right now. Next slide. And so when you share your story, there's a bit of bravery that comes with it because you're putting yourself out there. But we want people to know that bravery isn't just about sharing your story. It's about what your story can do and how it can save lives. That your one individual story can actually save lives, whether it's myself or someone with oropharyngeal cancer, someone with vaginal cancer, someone with any type of HPV related cancer. Those stories are brave and they can save lives. So always include patient stories. Next slide. And we do that when we share those stories. We empower others, not just here in the US, but around the world. We can lead by example. Next slide. And we cannot do this work without remembering those who no longer have a voice, who have died from a cancer, cervical cancer, that we can prevent. And so while I share my story, I share their stories too. I share Katissa, Erica, Laura, so many people, Becky. I carry them with me each and every single day. Next slide. And I want you to always keep in touch with me and keep in touch with the organization because we're here to help support your work and this mission that we can eliminate cervical cancer and HPV-related cancers together. Next slide. Next slide. I wear many, many, many hats and I love them all, but the one that I cherish the most that without cancer wouldn't have come into my life is next slide. My son Chayton, who gave me all these germs that I have right now while doing this presentation. Um, the cancer community, cervical cancer didn't win when it took my fertility away because in a crazy way that you'll have to use that QR code and learn about if you don't know, I became a mom. But I know my story easily could have gone the other way and I not be here today. But I wanted to end on this high note of the way that cervical cancer did not end and what it did take away, but in the end, it gave me this. But cervical cancer is hard. It is something that no one should go through because we have the tools to prevent it. And we have the tools to also save people from other HP related cancers. So let's keep that momentum going. This is a great day to recommit to that. And I thank you all for allowing me to not only share a bit of my survivor story, but also my communities too. Thank you so much.
Thank you so much, Tamika. It never gets old for me to hear your story. Every time I think of a different element of how, you took a very difficult situation and have made so much impact and change in really the work that all of us do each and every day. So thank you for always being willing to share and to inspire others. Speaking of inspirational people, it's my privilege to introduce our next speaker, Dr. Heather Brandt, both a friend and a colleague. Dr. Brandt directs the HPV cancer prevention program at St. Jude's Children's Research Hospital, which was really a very visionary idea to recruit someone like her to a place that focuses on children and adolescents. She's the Associate Director for Community Outreach in the St. Jude Comprehensive Cancer Center, and she's a faculty member in the Department of Epidemiology and Cancer Control. She is a social and behavioral scientist and an implementation scientist. I've learned a lot from her in terms of her research program and the way that she uses innovative approaches such as working with partners, understanding big picture context to address cancer-related health disparities, particularly in HPV vaccination. And her research, as I mentioned, includes working with subject matter experts. She works with thought leaders, and she is a thought leader. She works together to partner and implement effective evidence-based interventions and strategies that will expand HPV vaccination coverage. So with that, Dr. Brandt, take it away.
Well, thank you, Dr. Vatiparampil, and hello, everyone. Lovely to be here today. It's not every day that I get introduced by the recipient of the Researcher of the Year Award at Moffitt Cancer Center. So special kudos to you, Dr. Vatiparampil, for your leadership in our space. Congratulations to you. So I am Heather Brandt. I have the great privilege of leading the St. Jude HPV Cancer Prevention Program. And today is our program's 5-year anniversary of our official launch, which was on March 4th, International HPV Awareness Day in 2021. So our program really came to be because of the commitment of St. Jude leaders and researchers who acknowledge the importance of entering into this space. And the reason is quite simple. We are serving through St. Jude the same parts of the country that have low HPV vaccination coverage and high HPV cancer rates, as you saw in Dr. Giuliano's presentation. So in our program, we envision a world free of HPV cancers, and we are heading in that direction. Just last week, a study was released to show that in areas of our country with the highest HPV vaccination coverage, we see an almost 12% reduction in cervical cancer incidence over the last 20 years. We also saw a study come out in the last week from Sweden with 18-year follow-up data showing us that this vaccination is durable and does provide long-lasting protection. And our conversations about elimination are real. We know studies in Denmark, Sweden, Scotland, the UK, and Australia, among many other countries, are showing 0 new cases of cervical cancer as a public health concern. These are exciting times to be working in this space. Next slide. So our program has chosen to focus on-time HPV vaccination for all children through our national, regional, and local programming. And we understand specifically there are groups of children, as Dr. Giuliano showed, that in rural areas, choosing rural life shouldn't be choosing to be at higher risk of HPV cancers. And so special attention to populations that have lower coverage and lower rates certainly is a focus of our program. So we have national programming as shown here, our regional programming, including the HPV Vaccination Roundtable of the Southeast, which I'll be spending most of my time on today. We have local programming, and also a number of other activities that are offered through our St. Jude HPV Cancer Prevention Program. I want to mention that locally, our work in Memphis has generated improvements of HPV vaccination coverage about 15% over the last 5 years. And we continue to see those increases through our coordinated investments in collaborating with like-minded partners who share our vision, and also putting in the appropriate systems and structures to support delivery of HPV vaccination. Next slide. So today on HPV Awareness Day, our program has annually released at least one seminar. This year, we have 5 seminars for you to take advantage of, and you can access those at stjude.org/HAD 2026. One of these includes your very own Dr. Erin Kobitz, who will be presenting here in a few minutes following my presentation and others on Florida Forward, the elimination effort that is being spearheaded collaboratively across your state. So take advantage of these seminars to learn more, not only about our programming, but about the landscape of HPV vaccination in the U.S. Right now, we are faced with many contextual challenges and conditions that can make our work very hard. But while we're talking about it, commiserating, and thinking about all of the challenges before us, people like Tamika and all of those faces that she shared with us during her talk today are being diagnosed with cancers that we may be able to prevent. Next slide. So on our St. Jude team, we have 2 members who are leading our Southeast Roundtable efforts, Maddie McNee and Samantha Wells. Samantha also serves as our contact for the state of Florida. They are busy preparing for an in-person meeting of the Southeast Roundtable on March 9th and 10th. So next week, Monday, Tuesday, here on the St. Jude campus in Memphis. So we're excited to bring our partners, including several folks from Florida, here to continue these discussions to facilitate this cross-state, cross-jurisdiction learning that is so critical. Next slide. So let's talk about the Southeast Roundtable for just a moment. So the Southeast Roundtable formally started a couple of years ago, and this was building on previous work of the American Cancer Society and the ACS National HPV Vaccination Roundtable, and we continue to partner very closely with them. They previously had brought together a smaller number of southern states to really take on these challenges of low vaccination coverage in areas with high HPV cancers rates. So the COVID-19 pandemic sort of slowed these collaborative efforts, but we were able to bring back together and expand to include 12 states and 2 jurisdictions to really amplify our efforts and understand the potential for our collective impact. This is such a rich learning environment. There is a lot of amazing work happening across all of these states, and it's going to lead to all of us achieving that 80% threshold for the Healthy People 2030 goal for HPV vaccination coverage. Next slide. So we have come together because of low coverage, higher rates. We also have seen higher levels of vaccination hesitancy across the Southeast. We've seen fewer strong provider recommendations, and that can be a product of the context and conditions in which healthcare providers are practicing. We always want to believe all public health professionals, all healthcare providers and professionals are pro-vaccination, but I think we've seen some evidence that there is some reluctance in some cases. And so our job is to ensure that we are building systems and structures in support of these strong provider recommendations. We know there are a lot of prevalent myths and misconceptions, not just those that are perpetrated across social media channels, but those that happen among people's social networks, their family and friends and coworkers. And we know that in spite of the tremendous advances of Medicaid expansion, In this region, several states have not yet expanded Medicaid, and that continues to cause challenges for access to vaccination coverage. Next slide. So by coming together as this Southeast Roundtable, we have the chance to take advantage of our shared learning and build this community to be able to brainstorm when challenges emerge and identify solutions for moving forward. We know that the good work that's happening has the potential to work in other areas of this region. And we can collectively bring those together and push those forward for greater improvement and protection. Next slide. So in January 2024, using a highly iterative process with subject matter experts, thought leaders, and those with lived experience, we identified 3 priority areas of action: communication, elimination, and scaling efforts to start at age 9 and implement other best practices. And today I want to focus on the elimination goal. Next slide. So when we use the term elimination, I always think it's important to level set. This was alluded to by Dr. Giuliano in her opening talk. When we define elimination, it is that 4 cases of cervical cancer per 100,000 women. Elimination is not synonymous with eradication. So it's an important level setting concept to define. Next slide. And of course, the World Health Organization has been leading these efforts for cervical cancer elimination. Starting in 2018, the WHO Director General then issued this global call for action and has set this 90-70-90 target, with vaccination being at 90% of girls, though we have seen many countries retain our US focus on gender neutral vaccination. So through these pillars, you saw the 3-legged stool, which is a common image used. You can see that elimination rests on these 3 important pillars. Next slide. And previous research that has been published has shown us the importance of combination approaches that encompass vaccination and screening, as well as timely treatment. And so this modeling study showed that scaling up screening may have the greatest impact, and vaccination is crucial for sustaining those long-term gains. So this is the important piece here, that there is a need for these integrated strategies that include vaccination, screening, and timely management to truly close gaps and accelerate our progress. This is why regional action and state level action, like what we're discussing today, becomes so critical. Next slide. So having established this elimination priority for the Southeast region with an elimination implementation team, we started developing resources to begin these conversations. Alabama was the only state in the US that had issued a formal elimination plan. Florida has had the elimination goal, other states had that, but Operation Wipeout from our colleagues in Alabama was the first plan introduced in the United States, and the Southeast region introduced the second plan and the first regional plan. Now, Louisiana has introduced the Bayou Blueprint, and we'll also have a slide here shortly that shows some other work in progress, including Florida Forward. So we started doing an informal landscape assessment. We did formal interviews and surveys of thought leaders from across the region as well as nationally to better understand the context of the current conditions underlying HPV cancer elimination, starting with cervical cancer. And so that is what led to the release of the regional plan on September 9th. That's when the Southeast US call to action for the elimination of HPV cancer, starting with cervical cancer as a public health concern, was put out into the universe. And you can access these resources through the vanity URL shown there. Next slide. Here's an at a glance look at the 3 primary goals. Each of these goals has a specific set of strategies available to support. Having a plan is the first part. It's how the plan is implemented that really matters. Next slide. So you can also access a toolkit to help facilitate implementation, provides practical guidance for putting the elimination goals into practice. Next slide. So here's a collective list of the various resources that are available in support of elimination. And next slide, these include regionally tailored communication materials. And if a state is partnering with the Southeast Roundtable on the call to action, we're able to support building out these resources in English and Spanish for a particular state that is very tailored to state level needs. Next slide. So a plan is a plan. You've got to figure out how to implement that plan. But without evaluation, we won't understand fully if we hit our marks. And of course, the goals set us up for that success. But evaluation entails a little bit more than just the yes or no for those major outcomes. So we have been working with the implementation team on applying the REAIM framework as an example for evaluation. Next slide. And this is why it's important to also focus on state level evaluation. So not just across the region, which is of interest to the Southeast Roundtable, but also state level resources. Next slide. So our team members have been very pleased to work with many of the thought leaders across the state of Florida on Florida Forward. And we do offer this technical assistance to those in other states across the Southeastern region. Next slide. You can request to access any of our elimination materials by using the vanity URL, excuse me, on the slide, or the QR code. Next slide. So here's a high-level look at what's happening across the United States, Florida Forward, right there in the middle as being in progress. We know there are several other states that are also working to bring together these teams. And just to note, Tamika Felder and Francisco Garcia are co-leading the development of a U.S. national plan with the support of the American Cancer Society. So that will be coming soon. Next slide. So we have a tremendous opportunity before us to prevent HPV cancers. The conditions before us may be stormy, but we know that there are brighter days ahead, sunny Florida days ahead for us in our work here. Next slide. And so our job is to figure out how we are able to do this. And each of us who's joined today, the many partners with whom we collaborate, we are all key ingredients because preventing HPV cancers starts with you. It starts with each of us. Next slide. So please do join us if you're interested in learning more about the regional work of the Southeast Roundtable. As I've said a couple of times, we're very pleased to work with our partners in Florida on efforts to improve HPV vaccination coverage. Next slide. And thank you. Please reach out to us with any questions. We're really excited about the promise and potential before us. And now more than ever, our unification and collective efforts are going to keep us moving forward and ensure that all children are protected against HPV cancers they may develop in adulthood. Thank you.
Thank you so much, Dr. Brandt, Tamika, and Dr. Giuliano for those opening remarks. And we're a little bit behind schedule, but I don't think that's anything that's not overcomable and still to end on time. So we have just a little bit of time for questions, and I was trying to answer questions in the chat so that those are done. But one that I think Dr. Brandt would be directed to you is, are there any of the seminars that you all offer available in Spanish, or is that a future state?
Thank you for that question. At this time, our seminars are currently only available in English, but I do appreciate and will take that suggestion back to our team. We have worked closely on Spanish language materials with some of your colleagues in Florida and also in Puerto Rico, for example, where they have implemented an island-wide campaign using these materials. So, yes, let us please explore that to see how we may be able to meet that need.
That's great. And I think at our Southeast Partnership meeting, that would be a great topic of discussion. So thank you to the person who asked the question. All right. And it looks like the other two questions in the chat were answered. So we will keep moving along to our next presenter. And I am super excited to introduce Joe Thomas, who is the medical director of the West Virginia Department of Health in the Division of Women's and Family Health. My team and other people have always heard me say, let's not reinvent the wheel. If there's a state or a group that's doing something that we aspire to do, and that's how Joe and her efforts came onto our radar. She's a board certified family nurse practitioner and has over 25 years of dedicated experience in the oncology field. She's currently the medical director, as I mentioned, of the West Virginia Office of Maternal, Child, and Family Health. She leads the breast and cervical cancer screening program at the West Virginia Family Planning Program and oversees critical initiatives aimed at improving health outcomes and through early detection. She's a specialist in the full continuum of cancer care and women's health, and her experiences range from prevention and early detection to treatment and palliative care. So I think you can appreciate kind of the span of what we're trying to do as a state as well. So we're so grateful to have you, because it's very clear that you are committed to the same things that we are, and we would love to learn from West Virginia about how we can do things differently or potentially better here in our state. So with that, Joe, thank you so much for joining us.
Well, thank you so much for that very nice introduction. I'm so happy to be here today. So we're going to talk about HPV self-collection implementation, specifically within our West Virginia breast and cervical cancer screening program. You can go to the next slide. I have the objectives listed. We'll review some of the statistics. We won't go into too much because you've heard a lot of it already. Talk about our BCCSP program, the HPV self-collection, how to determine who's eligible, our process that we've used to implement it, the barriers we've come across, and then how we plan our implementation. Next slide. And I have no disclosures. Next slide. So the reason that we talk about cervical cancer is because it is a fully preventable and curable cancer or disease if detected early enough. So the WHO goal to eliminate cervical cancer, meeting the following targets by 2030, will place all countries on the path towards elimination. So by 2030, we want to see 90% of girls fully vaccinated with HPV by the age of 15, 70% of women screened using a high-performance test by the age of 35, and again by 45. And 90% of women identified with cervical disease receive treatment, 90% of women with precancer treated, and 90% of women with invasive cancer managed. Next slide. And we know that cervical cancer is about the 4th most common cancer in women globally, so not just in the US and not just in our state. Each year, about 13,000 new cases of cervical cancer is diagnosed, and again, about 4,000 women die from this cancer. And I can speak from experience because I do also palliative care and hospice. I have recently, just in the past few months, taken care of women who are dying from cervical cancer. And it's just very disheartening knowing the potential we have of where we could be with this disease, and we still see people dying from it. So our West Virginia Breast and Cervical Cancer Screening Program, it's federally funded through the CDC through the National Breast and Cervical Cancer Early Detection Program. We call it MBCC EDP. The goal of this program is to decrease cancer incident, mortality, and morbidity by focusing on populations who are underserved and who have increased cancer risk due to health inequities. The program has experienced an overall decrease in the percentage of women who have never been screened or haven't been screened in 10 years for cervical cancer. And I think that's probably nationally as well. But specifically in our program, that's where we need to focus and put our efforts, because we're really seeing those numbers low. And if you noticed on one of the slides earlier, West Virginia is in the red for the highest incident of cervical cancer. So we know that cervical cancer incidence and mortality are higher in these low-income counties and for individuals with lower incomes. That is associated with reduced access, along with lack of screening and additional risk factors. Next slide. So how are we going to get these numbers increased? So the HPV self-collection device was approved back in May of 2024. I'm just going to talk about two of them. It's the two that were approved initially. So the use of the self-collected vaginal specimens for primary HPV screening is an opportunity to expand access to cervical cancer screening for unscreened and underscreened women. So again, they were approved by the FDA in May of 2024. There's the OnClarity HPV and the Covus HPV. For women to be eligible, it's for women who cannot or do not want a pelvic exam. So initially, you ask a woman if, do you want a pelvic and do you want a pap smear? If she says no, and she meets the other eligibility, she can definitely do the self-collection. So it was ideally thought for women who have had trauma, maybe they have some type of physical disability that limits them in having a pelvic exam. So in talking with some of the other clinics, the providers are actually saying, hey, do you want a pelvic and pap today, or do you want to just collect this yourself? So you can have a different angle with how you're proposing that. It's for women who are 30 to 65 years old, because that's the group that qualifies for HPV only testing. They cannot be asymptomatic, not high risk, and eligible just for the primary HPV screening. We feel like this is going to be an important step and process for our areas that have really low screening rates. Almost 30% of eligible women with a cervix in the US can't or don't get screened for cervical cancer at the recommended intervals. So we're really hoping that this is going to help bridge that gap. Next slide. So where do we start to figure out how to do this process? So also keep in mind, we are a state program that is federally funded through the CDC and the MBCC EDP. So there are lots of things we have to go through and cross T's and dot I's and so forth to get things approved. So it's been a very, very slow process, but we are getting there. So we started with some research. What's available? What's out there? Is one recommended over the other? Do these HPV self-collected tests, are they accurate? Do they work as well as a clinician test? So we did some research. We sent a survey out via our listserv to our clinical partners. So all of our BCCSP clinics, we sent a survey out to, and I'll show you that in a minute. And we really just wanted to get a feel for, have you heard of this? Are you already using it in your clinic for your other patients? Then we had a steering committee meeting. I asked for volunteers, and we kind of had some champions in areas. We did a steering committee meeting to kind of guide and direct the process. We looked at all the different collection devices, and we had to take into consideration the lab and how to get the results piece of it. Next slide. Clinical studies like the self-serve trial have shown that self-collected vaginal samples are as accurate as clinician-collected cervical samples for detecting high-risk HPV. And these studies are important, especially to give to our providers, because when you have someone that has been an OBGYN or a GYN for the past 30 years, and they've done a pap smear every year or every 2 years on women their entire career, it's very hard, very difficult to entice change in these providers. So the way that it's written, the recommendations are written, is clinician collected is always preferred. So in doing a little more reading about that, the rationale behind that is because in the United States, we don't have long-term data that tells us what the outcomes are for these HPV self-collection kits in the process. They do in other countries, and it's been very successful. So until we have long-term data, I don't know that they'll change that sentence in the recommendation. So at the time, there were 2 FDA-approved swabs available, which I mentioned. We found out that the swab requires a very specific lab analyzer to process the specimen. So the swabs that were available, we couldn't just send to, for example, we use LabCorp frequently, or Quest. We couldn't just send it to LabCorp or Quest. They have a very specific lab analyzer that has to be used that isn't available at all labs. So that was another process to work on. Under the federal guidelines, HRSA and the American Cancer Society, self-collection is now a recommended screening option. Most private insurance plans are expected to cover the full cost of these tests. And I did check within our state. We use MCOs for our state Medicaid, and all of the MCOs do cover self-collection as well as Medicare. Patient and provider education is readily available from many reputable organizations, including the manufacturers. Both of the manufacturers that I looked at, they did have good data, they had good education. And for our implementation process, we've used the majority of the tools from the American Cancer Society Cervical Cancer Roundtable. Next slide. So with our survey that I mentioned that we sent out, does your facility already have a protocol in place for self-collected? And as you could see, we had one, yes, they've developed a protocol, but have not started. Next slide. Does your facility have a protocol in place for self-collected colon cancer screening? So, of course, we had majority more of yeses on this question. And the rationale behind asking that question was to see, okay, if you're doing colon self-collection, what's your process like for that? How can we kind of mirror that for the HPV as well? Next slide. So these are some of the other responses that we received about the barriers. Lack of awareness and education. Many were unaware that this was even available or knew enough about them to talk about it or talk to their patients about it. Patient-related concerns. Patients are concerned, are they actually going to be able to collect the sample? What if they don't do it correctly or they don't follow the instructions? Are they not comfortable doing it? Logistical and administrative challenges. We didn't have any established policies, guidelines, administrative protocols, insufficient funding or supplies. Cost and access. The cost of the test, especially for uninsured patients and transportation to clinics, were highlighted as some perceived barriers. Unfamiliarity. Some respondents were unsure of the barriers because they just didn't know enough about it. Next slide. Okay, my numbers look strange there. So we had a steering committee. It was multidisciplinary. It included representatives from health departments, free clinics, and FQHCs. And this is our agenda that we went through. Next slide. So one of the recommendations when this approval came about is it has to be collected, these samples have to be collected in a healthcare setting. So what is a healthcare setting? Well, I feel like they probably just left it as a healthcare setting so you could define within your own constraints or your program what your healthcare setting is. So of course it could be a hospital, a clinic, but we are even partnering with our mobile units to do enhanced screening days. Just as a little side note, we are partnering with one of our mobile mammography vans, and we're doing a pilot where you can, if you are eligible for colon cancer screening, HPV screening, and of course your mammogram, you can have all of that done there when you go for your mobile mammogram. So we're really trying to take advantage of these mobile units. Urgent cares, quick clinics, pharmacies. We know that there are a lot of like minute clinics or places like that within pharmacies. Labs, they're drawing labs, they're getting blood work. Is that considered healthcare? And then any other entities that you might think of. I just think it's just important to have some type of healthcare. And I don't think that it specifically has to be a clinic, but you can look at that and you can, decide upon yourself what is going to work for you. Next slide. So we developed a standing order for the HPV self-collection process with the help of our group here at BCCSP and our steering committee. We use this as a standing order or as a protocol, however the clinics want to implement it. But this just provides all the information that they need, who's eligible, who can perform this, and it goes over the eligibility requirements. Next slide. And that's just the second page of it. So this is definitely a test that you do not want to offer to those who are pregnant if they have any abnormal bleeding, abnormal discharge, if they're having pain, if they have a history of a high-grade precancerous lesion or of a cervical cancer, if they're immunocompromised, such as someone who has HIV, they've had a transplant, they've recently had chemo, or if they have their cervix removed. Next slide. So the benefits and the challenges to this process, the benefit, ease of the test, it's non-invasive. More women are likely to agree to be screened, and it's very cost effective. The swabs themselves, if you can see this, it's literally just a Q-tip, and there's a mark where you hold it and you insert it, twist it, put it back in here, and you give it back to your provider. So it's very, very simple. It's just almost as easy as a urinalysis. And I think the cost for actually running the test is about $70. So it is pretty cost effective overall. So some challenges, implementing it in the clinic. How are we going to do that? Are we going to have, our champions at these clinics that are going to really promote and encourage this? So it's requires a lot of clinic education. We had to have a plan, make sure clinics had a plan for follow-up of abnormal screenings, make sure patients understand, yes, you can collect this yourself, but if we see something abnormal, you're going to have to come back in for a pelvic and additional testing, which I would like to think if you have something abnormal, that would more likely be encouragement to come back for that additional testing. And then just providing all the education to our providers and our clinicians. Next slide. So upon a comprehensive review of our BCCSP data, it was established that the participating providers utilized co-testing protocols. Notably, none had transitioned to standalone HPV testing as a primary screening modality. And I am not sure if other folks are seeing this in other states or within other programs, but we did not have one thing submitted for HPV only in the past couple of years. So my thinking is, and this is just a guesstimate because our guidelines have changed and they're clear for those of us who work within it and work with cervical cancer. Those guidelines are pretty clear, but I think for clinicians, it's just easier just to test somebody every other year, every 3 years, and do the co-testing. Next slide. So some of our strategic challenges within our program, we had some financial alignment issues. We had to finalize internal billing and reimbursement protocols. In January of 2025, Medicare approved a CPT code that's very specific to, we're using the OnClarity, that's very specific to that because it does the extended genotyping. And MBCC EDP follows Medicare's guidance. So we had to wait till we had that code approved for reimbursement. Figuring out how EHR system workflows to support the clinic level integration. Now, we have a very small handful of some of our very small health departments that continue to use paper, but for the majority, most are now electronic. And are you able to implement this order in your EHR? Is it something that's there? How are you going to track these results? How are you going to differentiate between self-collected and clinician collected? And what kind of tracking system are you going to have to ensure that these women get the follow-up that they need? And then, talking to these providers about the HPV only primary screening for eligible women, that they understand the eligibility and the rationale behind it. And it's something that, can definitely benefit their patients. Next slide. So we partnered with West Virginia University Cancer Institute, their evidence-based intervention program, which is a partner within our breast and cervical program. And they are going to help us with implementation and with the community outreach event. So it's very important to have strong relationships and have good partners so you can get some help and get some buy-in. So our process will begin with the selected pilot clinics. We have 10 clinics selected, and we will be going live the first week of April. We actually decided on a date. I think we have everything done. We're ready to go. We are going to hold some in-person and virtual trainings for clinics and offer technical assistance as needed. So for our 10 pilot clinics, we are going to go to each of those clinics between our team and the EBI team. We're going to go in person to each of those clinics to do in-person training and see how that goes and see what questions and things come out of our pilots, and then we'll do virtual. Granted, West Virginia is not a very big state, but it could take probably 7 hours to drive from the bottom to the top of the state, basically. And we have a lot of very rural areas. So we felt like getting out in person to help with buy-in would really help initially. And then we'll do the other trainings as we implement and onboard the other clinics virtually. Next slide. So what have we learned? Again, it's very important to foster strategic relationships with key vendors and laboratory partners to ensure operational alignment within the program. And again, I have no disclosures. I have no relationships or affiliations with labs. We chose OnClarity. They were easier to work with, and because they offered the extended genotyping, which some think's important, some don't, but their product was just easier to use, more cost effective. At the time we did the research. And again, it's just the company that we ended up with. And then we're using a lab out of Virginia. So the specimens will be collected and will be sent batched weekly to the lab in Virginia. The lab is going to cover the cost of shipping. They're going to cover the cost of the swabs. And then they have their own type of electronic portal for results. They'll send the results within 24 to 48 hours of receiving the specimen. And then there'll also be a portal that clinics can log on to look for those results. We've also partnered closely with our state cancer coalition. Our cancer coalition is known as the Mountains of Hope in West Virginia. We have worked closely with them to help get some feedback and push out some of this information. Engage participating clinics to gather critical feedback on the practical application of the process. Again, our clinics are our partners. We could not do this program without them. And even though we may, I might write a protocol or a standing order, it may not work in their clinic. We're not the ones there actually doing boots on the ground, doing the work. So we need to be very practical and ensure that the process works for everybody. And we want to maximize the value of existing patient-provider education rather than duplicating the effort. And I can't say this enough, that there are so many valuable tools related to HPV only testing and HPV self-collection. On the American Cancer Society Cervical Cancer Roundtable site, there are many resources that are very good. There's patient information, provider education. There's also a toolbox out there that's, I can't remember off the top of my head where it came from, but I was able to access a toolbox that you can design to meet your program needs. You can change it, critique it. So there's a lot of resources already out there because we talked about it and we were going to start developing our own resources. And then the more I looked, I thought, that's a lot of time and effort for something that's, already vetted. It's from the American Cancer Society. So, and then commit to the process. It is a substantial undertaking. It's been a very long process. For some, it wouldn't take quite as long. But again, we are working with state and federal funds. So it's just been slow. We're committed to a thorough process to ensure that we get high quality results. We don't just want more women screened. We want to make sure that we're getting the results that we need. Next page. So as I mentioned, it's very important to establish good partnerships with your external vendors and your laboratory stakeholders. Formalize that standing order or the protocol to make it more standardized across your clinics just for easier implementation. You need to know what is their EHR capability or the integration. Provide the education and training to staff. We're going to do outreach and education to our community to let them know this is available, and then launch with a pilot program with a small set so we can work out all of those operational challenges and refine and have this workflow exactly what it needs to be before we do a full-scale rollout. So what we did, and this isn't all included in the slide because we just started a few weeks ago and I'd already had this mostly done. So I started with the information like infographics from the American Cancer Society, and I send something out every Friday on our listserv. So I started with one about primary HPV testing only, sent that out. And actually I did get some feedback from providers about that, which was very good. And then we said the next one was a clinician communication guide about how to talk to your patients and educate them between HPV only and co-testing. So, and then the next week it was something else then this last week I sent out specific information about the HPV self-collection. So that is in order to lay that foundation. So they'll have a good foundation groundwork of education before we just spring everything on them. So that was kind of our plan, laying that foundation. Then we're going to start with our pilot clinics, get feedback, refine it just as it needs to be so we can do a full-scale implementation. Next slide. So if you have any questions, you are welcome to put it in the Q&A. And next slide. And next slide. If you have any questions about the HPV self-collection implementation, or any suggestions, my contact information is here. That's also our website here at the state of West Virginia. And I just can't thank you guys enough for having us present today. Thank you.
Thank you so much, Jo. This was exactly what we were hoping for as a planning committee, which is to hear really how you sort of took from concept the availability of HPV self-sampling to how you plan to integrate it, and in this case, in your statewide breast cervical cancer early detection program. So I can see kind of challenges and advantages of starting there, but this was really, really helpful. We have two questions, but directed to you. So the first one is whether as part of the Department of Health, you're doing any screening on anal pap smear, or if this is primarily focused on the breast and cervical cancer.
Our program, it is primarily focused on breast and cervical because of our funding limitations, we can only focus on breast and cervical cancer screening and prevention.
And then as part of the criteria, are you reaching, for example, trans men who have a cervix? Is that part of kind of the group that would be eligible through breast and cervical cancer early detection program?
Yes, anyone who has a cervix. And in West Virginia, one of the first things that was implemented, maybe day 2, when we got our new governor, is eliminated DEI. So we had to go and adjust all of our policies and all the language. There was also an actual bill that passed defining male and female. So we have to use female or woman. So, and in some places in our policies and things, it says for anyone who has a cervix. But for the majority, we have to put female or women, but it's basically anybody who has a cervix.
Thanks. And thanks for sharing kind of the context. Two more quick questions. One is, could you review if you're allowing co-testing or just primary HPV standalone self-sampling in your 10 pilot clinics?
So they are able to do co-testing or the primary HPV standalone. So the co-testing would not be part of this specific project and the data and things that we'll be collecting on that. Again, I think we're going to have a big learning curve for our clinicians to get them on board with HPV only testing because they're so used and adept to doing the co-testing. And one thing that I probably should have mentioned, I'm going to address this next question very quickly, is for the HPV self-sampling, the recommendation says every 5 years, just like clinician collected for HPV standalone. However, this specific company, until they have more data available, they recommend 3-year intervals. So that's what we're hoping is that we'll stick with the 3-year intervals. We just need to ensure that these clinics have a good tracking mechanism and follow up.
Excellent. Well, thank you again. Such great information.
Thank you so much.
Yeah, we're so appreciative, and I know quite a few of us may take you up on that offer to reach out to you
Please
as
do.
we start to brainstorm. So thank you. With that, now that we've covered HPV vaccination and cervical cancer screening and follow-up of abnormal results, that three-legged stool that Dr. Giuliano talked about, it's perfect timing, if we go to the next slide, to introduce our next speaker. Also a good friend and colleague, Dr. Erin Kovetz-Kerman. I've known Dr. Kovetz for a very long time. We both started obviously when we were 10 years old in this business, but she is a national leader in cervical cancer prevention and elimination. She's worked particularly in South Florida, where there is a mix of individuals who come from backgrounds, including the Caribbean and Latin America. She's advanced community-centered screening strategies, some of the earliest work documenting local variability in HPV-related risk, and also successful translation of HPV sampling from clinical settings to community-based programs. We've worked together in a variety of different capacities, but now I'm thrilled to be working with her as she's leading a statewide cervical cancer elimination initiative, and has done an amazing job of making us all feel included and part of cross-institutional strategies to improve the following in Florida, which is screening, early detection, implementation of evidence-based approaches. And I forgot to mention, she is also professor, associate director of community outreach and engagement, and also leads our Florida Cancer Control Research Advisory Council. So she's a busy lady. Thank you, Erin, for taking the time, especially today as you have your external advisory board. So with that, take it away, Erin.
Thank you so much, Susan. It is a privilege to be here with all of you today. A nice respite from our external advisory board meeting. So springboarding off Susan's comments and the last presenter, who I think did an amazing job talking about the challenges of implementing HPV self-sampling within clinical settings through BSEP, your success is laudable and hopefully something that we're going to be able to mimic here in Florida. So the 4 NCI designated cancer centers in the state of Florida, whose logos you see at the top of the screen, decided to come together to create what we call Florida Forward, which is our intentional effort to eliminate cervical cancer within the state of Florida, or at the very least lower the incidence to the CDC and World Health Organization's target of 4 per 100,000. Next slide. The emphasis for Florida Forward was sort of catalyzed, if you will, by the state cancer plan. Our cancer plan in 2020 to 2025, which was led by my colleague from the Moffitt Comprehensive Cancer Center, Clement Guede, included for the first time mention of cervical cancer elimination as a goal. And then this year, there was a much more intentional effort to expand that goal to include objectives and evidence-based strategies aligned not just with eliminating cervical cancer, but advancing progress in vaccination, screening, and treatment. And I'm certain that many of you who are on the call today participated in those working groups. Anna Giuliano, who I believe spoke earlier today and whose presentation I missed, given our external advisory board, really sort of whispered in my ear as the plan co-chair and now the chair to make sure that we continue to give significant emphasis to cervical cancer elimination, to maybe make Florida the place on the map that leads some of these efforts, given that the burden of this particular disease is elevated all across Florida. So there is a unique opportunity and obligation for us to make meaningful progress towards elimination. As Susan said, this is a multi-institutional initiative. It is representative of our collective interests, strengths, and commitment to working across the state of Florida for common good. And as you're going to see on the next slide, it really represents the input of the working groups and regional collaborative members who contributed to the development of the cancer plan. And so I think I mentioned very briefly that the new cancer plan emphasizes vaccination, HPV screening, improving access to treatment, and really addressing access disparities across the cancer control continuum. This plan is available for viewing online. If you put in Google CCRAB annual cancer plan, it will take you to the Moffitt Comprehensive Cancer Center, which is legislatively or statutorily responsible for administering the state cancer plan and has a beautiful spot on its website for the cancer plan. Next slide. So Florida Forward is the response to the cancer plan's commitment to eliminating cervical cancer. And what it does is bring together a working group of individuals organized across 4 committees. And as you see here, the leadership of those committees, we have Susan Vada-Parampil, Jonathan Hickman, Patricia Juden and Matt Schlumbrecht, Tracy Milgram, myself, Ramsey Saloom and Janice Krieger. And, Ramsey, Susan, and Janice are my counterparts at the other NCI designated cancer centers in the state. We all oversee community outreach and engagement. And our goal in those roles is to work bidirectionally with community partners to achieve common goals, with cervical cancer elimination being one of the consistent goals nominated by all of the community partners with whom we work across these disparate geographies. Our committees are meeting monthly. Florida Forward as a whole meets quarterly. And what I want to say here is that if you are interested in participating in any of these committees, we are more than happy to include you. All you need to do is send me an email or an email to any of the people listed on this screen, and we'll make sure that you are integrated into upcoming meetings, because we believe strongly that the only way that we're going to make meaningful progress on the goals and objectives related to cervical cancer elimination in the cancer plan is to work together. This is a huge lift and requires the insight and inspiration of many individuals working across disciplines to accomplish these goals. Next slide. So to date, the committees have worked on identifying different priorities, which are articulated here on this slide. In terms of prevention and vaccination, the goals are to expand pharmacy-based HPV vaccination access statewide, to increase vaccination update in pediatric and primary care settings, and to really support more enhanced provider education to normalize HPV vaccination. In screening and early detection, one of the major things that we've been working on closely with the Florida Department of Health is very consistent with the presentation that preceded mine, and really thinking how we formally integrate HPV self-sampling into our BSEP program to expand screening access for the most vulnerable women or people with cervixes in the state of Florida. In terms of diagnosis and treatment, the group is working to identify barriers to timely diagnosis and treatment across the state. We know that there are regional variability in terms of disease outcomes, which in part reflects stage of disease at diagnosis and access to cutting edge treatment opportunities to ameliorate late stage disease and its implications. Really trying to think about the integration of referral and navigation strategies with community partners to enhance access to timely treatment, including telemedicine for individuals who live in rural regions across the state. And in terms of data and surveillance, we're really trying to work closely with the Florida Cancer Data System, the Center for Medicaid, as well as ACA and One Florida to ensure that we have robust surveillance that helps us appreciate the breadth of cervical cancer screening across the state so that we can focus resources in areas where the opportunity for impact is greatest. Next slide. So, there's going to be a link here for if you want to participate. I don't think any of you can access the slide, but I do believe that the Moffitt team is going to be sending out updated slides after the presentation. And I've actually asked my colleague, Samantha Marticona, who's participating today on the call, to make sure that my email is included, as well as that of Susan, Ramsey, and Janice, so you can reach out to any of us to encourage to identify your interest in participating. And then just next slide, I want to talk about Florida Forward is supporting a cervical cancer elimination grant. The funding for this is coming from the Sylvester Comprehensive Cancer Center, but the reason it's coming from Sylvester is because all 4 of the NCI designated cancer centers work collaboratively on a pilot program that supports the regional collaboratives throughout the state in addressing plan objectives that are related to the constituencies that they serve through the application of evidence-based interventions. We have already awarded the broader non-cervical cancer grants for the rest of the state, but there was some money left over in the Sylvester pot. And so collectively, we determined that it was in our best interest to do an additional call around cervical cancer elimination. The projects must align with the objectives in the cancer plan. These are objectives 6.1 through 6.6 under goal 6. And ideally, we would like to maximize collaboration across cancer control collaboratives to ensure co-learning and the delivery of best practices for individuals within the regions who are at greatest risk of developing and dying of cervical cancer. The deadline is March 27th, 2026. If you have questions, Samantha, myself, Susan, Ramsey, Janice are more than happy to answer the questions or even to work with you in thinking about what an appropriate focus for funding might be. And with that, Juanita, I know I only have 5 more minutes, but I'm happy to stop presenting and to take any questions that the group may have for me.
Thank you so much, Dr. Kobetz. That was excellent and inspiring. So I'm going to just kick it off with one question, and we've briefly chatted about this. What is our sort of our steps towards getting to a plan similar to the way that we saw Louisiana and Alabama currently have, whereas we're sort of in progress on a slide that Dr. Brandt had shared.
So I didn't see Heather's slide, but I know the work that the Southeast Roundtable is doing, and I think in many ways that's the guiding light for what we hope to accomplish in Florida. And I've already been using much of the information that the Southeast Roundtable has disseminated to inform our progress to date. Susan, I mean, I think the next goal of the working groups, and you can also chime in here if I'm incorrect, is start to build out a plan that's aligned with the goals and objectives articulated in the cancer plan for the different parts of the prevention continuum for cervical cancer, from primary to tertiary prevention. And I think our goal would be to really formalize that plan in the next 4 to 6 months to make sure that it's appropriately vetted by critical stakeholders such as the regional collaboratives, and then ultimately to publish it and then to measure our progress against the plan itself.
I think we're on the same wavelength, and that sounds like an optimal horizon to give us time for the plan, which spans to 2030, the Florida Cancer Plan. So that's great. We have one question in the chat. How are you approaching the underserved population? So in parentheses, they say undocumented women and children to access vaccination prevention services. Is if there's cancer detected and the patient doesn't have legal status in the U.S., what program do you have to support these types of patients?
So these are things that we are working through, challenges that we are all individually working through as NCI designated cancer centers and other health system partners that I assume are represented on this call. You know, when we do screening in the community at Sylvester, and I think the same is definitely true at Moffitt, we're not asking anybody about their immigration status. What we're asking is questions to assess their cancer risk and to identify the cancer screenings for which they may be eligible. At Sylvester, we also work closely with a number of community partners who can offset the cost of follow-up and or treatment for individuals regardless of their immigration status. That's certainly getting more complicated given some of the changes to federal funding to those organizations. But we continue to stay committed to making sure that we can address the needs of all of the people with cervixes in Florida who can benefit from screening. And I think this is also another really important opportunity to underscore why HPV vaccination is so unbelievably essential. Not that there is any recommendation that you get vaccinated and don't continue screening, right? The recommendation is that you do both. But with more and more individuals vaccinated against HPV, we create a bit of a safety net, if you will, to ensure that there will be less likelihood of individuals developing invasive disease that requires treatment and may incur significant costs that go beyond insurability and or immigration status.
Thank you. And I totally agree with you. Each of our centers is deeply committed to serving the broader community, and our strategy is very similar to the one that Dr. Kobetz mentioned. One last question. I'm curious to hear your thoughts on this. I have some too. Is there a possibility that this vaccine will be mandatory for HPV vaccine will be mandatory for children, young people to enter the state school system?
I think I don't like to ever say never, right? Because we don't know. And a lot of these issues around vaccination are evolving in real time. I do believe that there's been an unhealthy amount of skepticism about the HPV vaccine since its inception, and people like Susan and Anna Giuliano and other colleagues have really been working to push against that tide of skepticism, to underscore the science that legitimizes HPV vaccination as incredibly, incredibly important for preventing not just cervical cancer, but other HPV-associated malignancies. I think that we are going to have to find other ways by which to maximize uptake of HPV vaccination than relying on a mandatory vaccine, regardless of how we feel about the population health benefit of doing so. My understanding is that there is going to be changes to some of the mandatory vaccinations that are required for school-aged children on a federal level that may trickle down to states. And so we're going to really have to work through other channels to strategize about how to drive vaccine uptake regardless of a mandatory requirement.
Thank you. I again, once again, echo your sentiments about sort of other strategies besides reliance on a mandate. And then the last question is, can the link be shared for Florida Forward and information about the grant? So we will definitely do that in collaboration with Dr. Kobetz's team. We'll disseminate that information very soon after this meeting. So we will do that. So with that, I would like to thank Dr. Kobetz as well as all of the prior speakers. We tried to be respectful of everyone's time and also attention span for a virtual or Zoom meeting. And I just want to thank you all again for hanging with us. And it's my privilege to do the wrap up. So I can't see all of you on the call. I suspect I know many of you, but just in case you don't know me, my name is Susan Bada-Prampel. I am the Associate Center Director for Community Outreach and Engagement and a researcher here at Moffitt. I've been here for the past 23 years and have always had a deep commitment to accelerating the adoption of evidence-based guidelines and practices in healthcare, including many of the ones that we talked about today. As part of my research program, I've evaluated strategies to improve shared decision-making, support follow-up of abnormal results, and integrate HPV testing and vaccination in a coordinated way to cancer prevention efforts. And I like to think that my work, along with the work of many others on this call, has helped to increase HPV vaccination rates, improve cervical cancer screening, and make sure that HPV prevention strategies are routinely considered as part of primary care and population health. So with that, I wanted to kind of close us out, talk a little bit about sort of next steps. So today you attended our HELP Summit. It is one of the few times that we've had it virtual, but as Anna mentioned, she and I have been co-hosting this summit for now over 5 years. We began with a partnership with the American Cancer Society, and then in successive years have been partnering with local community health systems such as Advent Health, Nemours, and most recently Lakeland Regional. This year we took a slightly different approach where we had a virtual meeting, sort of being conscious of travel fatigue and budget, but certainly are interested in hearing through the evaluation forum about your ideas for perhaps bringing this meeting back to in-person. Our goal is to convene healthcare systems, healthcare providers, leaders, community members, those involved in policy and advocacy to review and discuss trends and changes in HPV vaccination and cervical cancer screening, particularly in Florida, to identify barriers to HPV vaccination and initiation, completion, as well as cervical cancer screening. And today was really a milestone because we've always had this second piece of, okay, what next? And now we have Florida Forward that's going to carry forward the enthusiasm, the momentum that we have here today to work towards a state plan around HPV-related cancer elimination, starting with cervical cancer. And that's really the work of Florida Forward, and we're hoping several new members to the work groups to develop a strategy to get there by deploying evidence-based interventions related to HPV cancer prevention. Next slide. So I want to make sure to take a moment to thank our planning committee and our team for helping make this year's summit a success. You see the names listed of our planning committee, and they include both stakeholders from the community organizations, as well as from Moffitt. And I want to give a special shout out to a few members of the Moffitt team. Many of you have seen emails from Juanita and Mariana around the summit. So thank you for your incredible organization. And then behind the scenes, we also had Elliot Tapia Kwan, who did much of our social media, Julie Rathwell, who actually began the planning of these summits many years ago, Alma Ticinero, who is one of our management assistants, and then our COE leadership, our Center for Immunization, Infection, and Research Cancer, and Moffitt staff. So we'll go to the next slide. So I want to end kind of where we began, which is this idea of thinking global about the potential for cervical cancer elimination, but encouraging us all to think about how we can act locally. From our Moffitt perspective, we are committed to hosting a summit again next year. We would love to hear your feedback about whether you would like to reconvene in person, whether the virtual format works better for you. We're open to any suggestions, thoughts, ideas about how we can make this a meaningful experience for those of us that are interested in the prevention and elimination of HPV-related cancers. Next slide. So thank you so much for joining us. We hope to see you next year. And we've even built in time for you to please complete our event evaluation survey. If you think of any other questions, please feel free to add them to the Q&A. We're happy to address them now or in the future. But with that, Juanita, Mariana, is there anything else that we need to cover?
Nope, we're good to go.
We're good to go. All right. So they just scan the QR to be able to complete the evaluation survey. So please take a few minutes to do that. And we really look forward to convening next year, hearing about the progress of Florida Forward, our progress on the Florida plan. And we would love to have whichever group gets the cervical cancer community grant to come and share your experience and your process this time next year. Someone asked if we could put a link in the chat for the survey. Are we able to do that?
Yes, I can do that right now.
Okay.
Thank you.
All right, then I think our presenters are free to sign off, and we'll hang out here for a few minutes just in case anyone has questions. Thank you for the kind words. I am thrilled with the attendance of this summit. We're so happy that you all joined us.
And if anyone has trouble with the QR code or the link, I think as you exit the Zoom webinar, it also pops up. So just a heads up.
Thanks, Juanita. That's terrific. And Joe, I don't know if you're still on, but that was fantastic. It's so operational and like how we need to think. So I was great suggestion, I think on Heather's part, right, to invite Joe. All right, I'm gonna hop off because I've got another thing. Are we good?
Yes, we're good. Thank you,
Yes.
Dr. B. It's a wrap
Thank
up.
you.
Thank you, everyone.
Fantastic.
Have a great
Thanks,
day.
everybody.
Bye.